Good day, everyone. My name is Johnson Amo, and I work as a consultant obstetrician and gynecologist at Blackpool Teaching Hospital in the United Kingdom. I'd like to say a big thank you to the organizers of this conference, particularly for asking me to speak on the topic, newer devices and techniques in therapeutic hysteroscopy. I have nothing to declare. However, my interests are in office gynecology, benign gynecology, surgery, and minimally invasive gynecological procedures. The outline of my presentation as follows. I'll be looking at an overview of hysteroscopy, indications for therapeutic hysteroscopy, treatment of heavy menstrual bleeding, hysteroscopy tissue removal systems for fibroid, polyps, and retained product of conception, pain management at hysteroscopy, and hopefully arrive at a conclusion. Hysteroscopy, as shown in this short video, is performed for evaluation or treatment of the endometrial cavity, tubal ostia, or endocervical canal. Hysteroscopy basically is for diagnostic or therapeutic reasons. The setting where hysteroscopy is performed, it's very important. This could either be in the office setting or in the operating theater. The indication, as mentioned before, either for diagnostic or for therapeutic reasons. The skill of the operator is very important, and this will determine what procedure is performed and where it is performed. And this is also experienced with the equipment used. The distension media commonly are normal saline or glycine or even carbon dioxide. Pain management is extremely important, especially in the outpatient setting where patient is awake. And in the operating theater, it can be done under regional or general anesthesia. Complications of note include perforation of the uterus, and this could extend to bowel, bladder, or major blood vessel. There could be catastrophic consequences from fluid overload, either with glycine or with normal saline. Contraindications to performing hysteroscopy include an ongoing pregnancy, known cancer, or active infection. The indications for therapeutic hysteroscopy include treatment of abnormal uterine bleeding, and for the purposes of this presentation, for heavy menstrual bleeding, for removal of fibroid, endometrial polyps, intrauterine adhesion, lost intrauterine devices, retained product of conception. It could also be used for obtaining targeted tissue samples or biopsy, and lastly, for hysteroscopic sterilization for contraception purposes. In the management of heavy menstrual bleeding, options would include medical management using non-hormonal medication like tranexamic acid, or hormonal option using oral contraceptive pill or Mirena intrauterine system. Endometrial ablation involves destruction of the endometrial lining. And lastly, hysterectomy, which is performed via minimal access routes, either vaginally or laparoscopically. In order to achieve endometrial ablation, we'll look at the first generation devices, and these are the monopolar or bipolar resectoscope. They have been around for a while, and they require direct visualization of the endometrial cavity via hysteroscopy. They require formal training, and the safety profile of using these devices are user-dependent. Complications I've mentioned previously include perforation and fluid overload. In order to use this equipment, rather use the loop or the roller ball to achieve resection of the endometrium or ablate the endometrial lining. There are newer generation of ablation devices. They do not require hysteroscopic visualization of the uterine cavity. However, a prior assessment via hysteroscopy and tissue obtained to rule out cancer or hyperplasia is advised. The skills to use these devices are easily acquired, and as such, they're suitable for use in the outpatient. They are treated with shorter operating time, and they have a good safety profile. Example would include the thermal balloon ablation, as shown here, or bipolar radiofrequency endometrial ablation, for example, being NovaSure, and lastly, microwave endometrial ablation. There are newer generation ablation devices, and like the second generation, the difference here is the latex on the balloon being replaced by silicone to allow better distribution of heat on the endometrial surface. The skills are easily acquired and they have a good safety profile. Example would include the Cavatherm or thermoblade endometrial ablation device. The video shown here, the top one being a diagnostic hysteroscopy showing the endometrial cavity before and after endometrial ablation. Compared to first generation techniques, the second generation approaches are of equivalent efficacy for every menstrual bleeding, and they have a comparable rate when it comes to amenorrhea and improvement in pictorial blood assessment charts. The second generation techniques, however, are associated with shorter operating time and can be performed under local rather than general anesthesia, and of course in the outpatient setting. If there was a head-to-head comparison between bipolar radiofrequency and microwave ablative device, they are more effective than the thermal balloon or free fluid ablation devices in the treatment of every menstrual bleeding. Regarding tissue removal system, the traditional resectoscope, which could either be bipolar or monopolar, can be used. They require use of electrical energy. And as mentioned previously, the safety of these devices are operator dependent. On removal of the tissue, which could be polyp or fibroid, there could be difficulty retrieving the specimen, which sometimes can float in the cavity. And also due to electrical spread, there could be problem interpreting the specimen on histology as it is not well preserved. Fluid management is always an important factor that needs to be considered. Monopolar resectoscope require glycine distension media, and they are not suitable for use in the outpatient. The bipolar resectoscope have a better safety profile, and they use saline media distension. They are suitable for outpatient due to smaller diameter hysteroscope being available, as well as the vaporizing electrode like the VesaPoint. There are newer tissue retrieval system. In the picture, the top one being the Bugatti shaver, and below that is the MyoSure devices, either the manual or the automated generated ones. They show a major advantage in successful removal of pathology and the total time of operation. They are more accessible and can be used in the outpatient or operating theater for removal of fibroid or polyp. They have a lower complication profile, particularly of uterine perforation, creation of forced passage, and bleeding. They have a specific mechanism of action, which involves musculation and suction of a specimen. And most importantly, the skills to perform this procedure are easily acquired. For resection of fibroid, evidence would suggest that there's no difference in total procedure time between hysteroscopic musculation using the TrueClear system as compared to bipolar resection for removal of smaller type 0 or 1 submucous fibroid, as shown in the picture. Hysteroscopic musculation is faster, especially for small fibroid. However, the setup time can be longer and is of limited use in large and calcified fibroid. Fluid management can be a challenge, not due to perforation, but due to poor collection. For hysteroscopic polypectomy, using the TrueClear system, as shown in this short video, you can see the TrueClear device being inserted, and once on the specimen and activated, it creates a suction and the tissue is musculated and collected. It is a fast and effective and safe alternative as compared to the bipolar resectoscope in removing endometrial polyp. For retained product of conception, this short video is not removal of retained product, but it's used to demonstrate how the skill and principle can be applied in removing retained product of conception. Operative hysteroscopy remains a safe and highly effective option for management of retained product of conception as compared to traditional dilatation and curettage. The reason being that most times there's little or no need for dilatation, therefore reducing the risk of cervical trauma or incompetence, which may lead to miscarriages, preterm labor, and preterm birth. It allows for direct cavity assessment, therefore avoiding blind procedure and under or over cureted endometrial lining. It allows for precise and targeted resection, and as such, complete removal of retained product of conception. And there's less risk of intrauterine adhesions, which can affect fertility. The operation setting is important, and this can be done either in the office or in the inpatient, but with shorter hospital stay. I'm aware of cost implication, especially in low resource setting. However, patient choice and alternative has to be considered. Pain management in the outpatient would largely depend on the skill and temperament of the operator and the supporting team, especially in the outpatient setting. According to the review by Ahmed, there's no consistent good quality evidence or a clinically meaningful difference in safety or effectiveness between the different types of pain relief, especially for women undergoing outpatient hysteroscopy. However, in order to improve patient experience, the following can be considered: using the vaginoscopic or non-touch approach, distraction techniques or vocal local, using pre-procedure analgesia, either non-steroidal anti-inflammatory medication or tramadol, using local anesthetic or paracervical block, conscious sedation, and of course, regional and general anesthesia if none of the above is suitable, and this is for main operating theater. The future of pain management has been demonstrated in the recent randomized control trial and published in the VJOC using a virtual reality immersion device. This was performed in about 40 patients, and it has shown an effective outcome in reducing pain and anxiety during the outpatient setting. However, there still needs for further evaluation to explore the wider potential of the virtual reality in the ambulatory setting. So the future of ambulatory gynecology may look like this. So in conclusion, there's increasing demand for benign gynecological services, and this will drive innovation and development of a safe and efficient hysteroscopic equipment and devices, which are patient-centered and of cost saving. And more procedures will be shifted towards the ambulatory gynae setting. Thank you very much for your attention. These are my references.